I'm a child psychiatrist. I'm the Chief of Clinical Services and the Vice Chair of Western Psych. Just a little bit about my background where I work. Western Psych, the University of Pittsburgh, we're the biggest research department in mental health in the country. We bring in about $92 million in federal grants. So University of Pittsburgh, our psych department is fairly big into research. We're also, I'm a child psychiatrist, but I'm over the adult geriatrics, all the divisions. And so as the Chief of Clinical Services, in our region in Western Pennsylvania, we have about 400 plus psychiatric beds. We do about 40,000 new patients a year. We have 5 or 6 different sites as for our inpatient units, I think over 50 outpatient sites. So we're the biggest provider of mental health in that region. The other things we do, and you've heard some people mention community care, that's our behavioral health company. I'm on the board of that company, was their medical director. So community care, we have if people work in the county, who knows community care? A lot of people know, a lot of people's hands go up. It's a great, great managed care company. I was one of the original people who helped with that company and still on their board. So we do have a Medicaid company, and we also have a SCISA, Psych Consult, which is a software company. So we're pretty big, a big organization, and so I'm very lucky. I've been there for 23 years. And thank you for inviting me out here to speak. And what I'll be speaking about today a little bit is one of my favorite projects, that we've been working on. Over the years, we've developed a model in the pediatric practice to see kids. And so that's what I'm going to be talking about, the behavioral health integration, the primary care pediatric practices there. I talk very fast. I usually have somebody in the sign, John, to slow me down, slow down if I go too quick. Also being filmed, I can't use half my jokes I usually use because I'm a little embarrassed to use them on film. I may go cover it up and tell a few jokes if you don't mind. Everybody, the point's been made over and over today, but I'll just real quickly go through the couple of slides. There's a big need. 1 in 5 children in the U.S. are diagnosed with mental health disorders. 2/3 of the children don't get the adequate care. Suicide's the 3rd leading cause of death. These things have been repeated over and over again. This is not a minor problem. It's a big problem. Mental illness is the 2nd leading cause of disability and premature mortality in the U.S. And I've seen this over and over and over again from different reports. This is a very big problem. Some of the challenges the pediatricians face. The pediatricians have increasingly been called upon to identify and treat mental health and psychosocial concerns. Most of your psychotropics in most markets are prescribed by the pediatrician. They have limited training. I did a pediatric internship. I think the pediatric training has gotten a lot more, but it is limited. Limited time of each visit. I think about what our therapists do, and I've worked in pediatric practices, and I visit, I have 3 kids, by the way, and I visit those practices. They're busy. I always think that, I thought about pediatrics, but I couldn't really work that hard, so some video in it. But as a child psychiatrist, I don't have quite the pace a pediatrician does, but it's very difficult. The limited number of visits, so you can imagine when you have 4 or 5 people in an hour, where a child psychiatrist may have 2 or 3, it's much different, and a therapist less than that. So high frequency mental health concerns. In fact, in our market, we went out to the pediatricians, and you go to any practice, it was one of the top 3 things they needed help with was mental health and behavioral health. So, just in our area, most pediatricians were putting as one of the top things they could use help with in their practice. And limited access to the level for behavioral health referrals. And so it's hard enough when you're depression to get to the appointment, and then you get to, there's Dr. Brandy just walked in. Wait a second. Okay, good. You see my heart rate go up a second? I'm like, okay, that's it. This is the mission statement. We got together. We've always, I think we're about, Western Psych, we've had some pilots going on since the 80s. We actually had pediatrics, sort of a pilot going on. I don't know if people know John Campbell, wonderful child psychiatrist, triple board. He's actually the chairman at Columbus now. Great guy. He actually started it back in the 80s and 90s. He was running integrated pediatric, where he went to the pediatric practice, they have therapists there. So we've been doing that model for a long time, but to be honest with you, it wasn't making a big dent in the overall need. So the group got together, we wrote this mission statement. I like the mission statement. It was a committee that gets together every month with pediatricians, child psychiatrists, therapists. I've been trying to add family members and youth, not quite there yet, but the group has been meeting. And this is what we wrote. The Children's Community Pediatric Behavioral Health Program is a collaborative effort between pediatricians, licensed social workers, psychologists, and psychiatrists to provide timely access to high-quality, empirically supported behavioral health assessments, screening, behavioral interventions, and psychiatric, I push screening in there, by the way, and psychiatric interventions to children and families in an integrative model provided within the pediatric care office. We've already been doing it for a long time, but we wanted to really grow it. We wrote this mission statement. I'll tell you what we're doing with that. Some of the goals of this project was to improve the access to behavioral health interventions, to improve the clinical outcome, to reduce the barriers to get this mental health services, develop a high quality. Why we put financial sustainability in this model, we were trying to see, we wanted really to grow it to all the needs. So we really worked, and I'll show you a little bit of my expertise a little bit on this, where we'll show you how we made it financially sustainable without a grant. And we've had grants in the past, but we wanted to make this really financially sustainable on its own for primary care health treatment and decrease the stigma and also to improve communication among the team. that was our goals. This just shows you a little bit of the group when we got together, sort of visualization of it, with the patient and family, the pediatricians, the psychiatrist, and the therapist. So let me tell you the setting for our collaboration. We started with, I could also talk today about our consultative, on a side note, our consultative service is sort of going through the same thing. Our consultative service also does all the specialty clinics. So in that model, I think it's about 8% of the patients at the Children's Hospital get a psychiatric consult. I think it's like 7 to 10%. It's really grown. We also have a lot of therapists. We have several therapists now in the specialty clinic. So that's a different project I'll tell you about. This is actually the one where these are the private practice. Well, not the private practice. They're the frontline community pediatric practices. 146 pediatricians, 20 practices. 16 of them now have some type of what we call the Family Counseling Center location. 33 different offices in 10 different counties, too. What's nice about this project, too, some of the practices were Medicaid inner city, some of them are in the suburbia, some of them are in other counties. So there's 10 other counties, too. Now this is the other part of the collaboration, which we are up to about two FTEs. You can see I wrote the slides. These are full-time equivalents, but we have 2 child psychiatrists. There are actually 4 psychiatrists and 3 are triple boards. Big shout out to triple boards. We have a triple board program, and I think that the triple boards are really good. We don't always use those triple boards, but the triple boards particularly do well in this kind of model because they really can talk to the pediatricians. And so we use a lot of triple boards in that program: child psychiatrists, child, adult, and pediatricians. We're up to 10 full-time therapists in the pediatric practices. We're growing about 1 or 2 every 6 months, so we're really growing that a lot. These are full-time people in the pediatric practices, 10 therapists now. They're in 13 different locations, so we're not full-time. You don't have some therapists will go to 2 different offices, and then we have, it shows you different locations. The collaboration was between 3 big people. The Children's Hospital, the way it's set up there, they have a Children's Hospital, and then we have all the pediatric practices, which are under Children's Hospital. Western Psychiatric Institute and Clinic, where I work, and we also did the pediatric practices. Let me walk through how we did this. This is a real busy slide, but let me tell you how it works. I think it's somewhat people think, how do we do this? What will happen, by the way, like I'll see a pediatrician with my child. In fact, I guess I could tell one personal story here. I guess I'm on video. My 10-year-old will kill me. My 10-year-old has diabetes, and we were having really, when he got at the onset, we were really nervous about it. So he was in the pediatric office, and we're sitting there working with the pediatrician. I said, he may need to talk to somebody about this. And he really looks nervous about it. By the way, I'll tell you the story. He wasn't nervous. I thought he was nervous. And so we went to we go to the front desk. They schedule you right there. In fact, I went over and met the therapist right then. Gretchen, she came over in one room, introduced you. This is the therapist you're going to see. So it's not, the pediatrician just walks over and introduces you, or the nurse. You walk out, you make an appointment. They share the same schedulers. You schedule right there. In fact, when I sign in on the pediatric list. And then that afternoon, the therapist saw my child. Actually, a funny note, after 4 sessions, we're in there going, is he doing okay? We're a little teary-eyed. I said, yeah, your kid's really fine. I think you're having a hard time dealing with it. So what's interesting it's like we were the identified patients, we found out, like typical thing. He's doing great, by the way. His hemoglobin A1C is like 6.5 the last week. So he's never had a problem, actually, with it. He's a very amazing kid. And we're doing better, too, by the way. The therapy did help us. We're dealing with it much better. So, but it was interesting, by the way. Look at us. So we went there. That's what the normal process is. You go right there. You schedule right there. You leave right there. And so what's interesting is the therapist then does a 60-minute appointment. A bill is I get into this sort of operation stuff. Sorry, you also. So the bill was actually generated to the behavioral health payer. A lot of work went on to make sure the behavioral health payer will recognize that therapist. What we didn't want to do is make it a licensed clinic. If you make it a mental health licensed clinic, you fall under some. There's a lot of handshaking back there. Everybody said the minute you make it a mental health licensed clinic, by the way, we did that. We did that pilot, and that's really difficult because you have a lot more regulations on that. So we bill under that individual therapist license underneath the pediatrician. Now, 5-axis diagnosis. We haven't moved the DSM-5 yet, but we're still doing the 5-axis diagnosis. They actually enter their note right there in Epic. Epic's been right there in Epic, so there's no handoff at all. I mean, you're right there entering, like the nurse practitioner would be. By the way, we do have some sites we have a nurse practitioner who does some of this too. And then there's an evaluation sent right to the pediatrician's message box on Epic that shows, hey, you've got a therapy note. The therapists begin the intervention right there in the pediatric office. Then after you go out, you schedule right there for your follow-up. One thing is the psychiatrist. I'll try to tell. We've had one thing is On a side note, I put my term, I have a little bit of a Kentucky accent, I call it naked doctors, but I don't like to use, I always do this in meetings, I don't want any more naked doctors. What happens, by the way, I've been trying to do this in adult, but in adult, our ratio is bad. In adult, we have a psychiatrist maybe with 1 therapist. We really do have a model of 10 therapists with 2 with the child psychiatrist. The model works much better because what we have in our adult world, I'm trying to put adults in primary care, my adult psychiatrist, and the problem with it is they don't have a therapist there, and they're not as integrated as good. And the first 10 referrals take about 20 hours. Your first referrals from that primary care doctor are not very simple, and you're spending hours with these very complex cases, and the reimbursement's not that great. Now, luckily, we're sort of an expert center on E&M billing, so E&M billing helped us a little bit. I can tell you all about E&M. I have a whole lecture on E&M billing. But it's interesting, by the way, we haven't been able to be successful in adult, possibly because that ratio is a lot more the psychiatrist without the therapist. And so then the 60-minute referral, it's right there. Patients seen regularly, weekly, bi-weekly. One thing we do, too, by the way, in a mental health clinic, you tend to hold on to your patients. You don't tend to discharge. Somebody gets better, you don't. Here, because you know they're going to keep on coming like pediatrician, we'll see somebody 3 or 4 times, they're doing better, you'll discharge them. The pediatrician will keep falling, and they'll refer back. So we do tend to have a much, much different, with the same patient population, their turnover is much different than a mental health clinic. It's much like a medical home, because even though you may not be seeing them regularly as a therapist, guess what? They're coming back to your clinic every day because it's the pediatric practice. So it works much better. We have team meetings. One thing interesting, too, by the way. Am I talking too slow? Too slow right now? I'll slow down a little bit. What's interesting, too, by the way, the way we work it, too, the child psychiatrist actually helps with the supervision of the therapist, or the therapist supervises them, and then they report in there clinically to the child psychiatrist, but then they actually belong to pediatric practice, which is sort of an interesting model. The child psychiatrist does come on site and does come back to the hub. Some of our places we've actually, where the pediatric hub is, which we're having a lot of child psychiatrists go and triple boards out to the pediatric office, but sometimes they'll go back to the main pediatric practice, which is a big, like sort of a hub. That's where most of our child psychiatrist time is. It was hard to get them always out to the office. They do go out there some. The welcome medications, but you can see the consultation of the psychiatrist if needed, while sometimes the psychiatrist will see them, and they'll send them back to the pediatrician after they get the medication stable, because they're all in the same practice, so it's not a big deal, especially when they're pediatricians too. So there's a lot of going back and forth, just like in a pediatric practice, where if somebody's stable, the pediatrician will follow up with them if they need to in that time too. Even the consultation is nice because you feel like you're in the same practice. So it's when I go over and talk to my fellow in my child psychiatric clinic, I don't call them, I'm doing a consultation. I'm just going over talking to my same practice. These child psychiatrists, mainly because they're triple boards, actually feel like they're part of the same practice. So it's not like a consultation. You're talking to your peer who's right there in the same practice, which makes it a lot better model there too. By the way, there is a lot of we had to be careful because we have a hard time, I guess I'll talk budget here for a second, about financial stability. That we did lose some money on the child psychiatrist. We were able to make it up on the therapist enough to break some of it more even, because the child psychiatrist, especially in startup, was getting called all the time for sort of for those kind of consults, but now we sort of have a balance with that too. Also, it's interesting, if you have the therapist there, and you have them be able to intervene that day, they can actually call the child psychiatrist too and say, hey, the pediatrician's worried about this case, this Tommy. They'll say, hey, why don't the therapist see him right there this afternoon? The therapist then might call the child psychiatrist, not the pediatrician have to call the child psychiatrist. They're going to open up their Epic, and there's a note about it. This is a very interesting slide. I showed it a couple days ago to a group, and they really beat me up on the slide. Somebody beat me up too much. It's very interesting because the number of sessions was less than people thought. And our fallout rate, people feel like they're getting success. But if you look at it, there's a lot of people that will come in there are some people, we do about 12,000, I think we're up to about 12,000 visits a year now in the pediatric practice. It'll keep on growing because the need's out there. But if you look at it, about 474 of the kids had 6 or more visits. 665 had 3 to 5 visits. There's a substantial amount of them that had 1 visit. And what's interesting was that was probably because we're getting a lot younger age group, and we're also getting them in the first crisis. This age group's about 2 or 3 years younger than the same diagnostic similar group in a mental health clinic. So the pediatricians, because they have it, they're much more likely to say, wow, Tommy's lost a whole week of sleep. Let's go get him to see the psychiatrist. I think we're getting them earlier in their episodes, too. Now, also, too, I'll show you later, we do have a very good mechanism if they need to go to our clinic. I mean, we saw 40,000 people in we have a pretty big active outpatient clinic that we will send to when they need to. I'll come back to that. This shows a little bit of a referral. The mild behavioral health symptoms and impairment, they'll be seen by the pediatrician, and then they have moderate, they'll get seen by the behavioral health collaborative team, and they have more severe. We do actually, one thing nice is we run the Allegheny County. For all of Allegheny County, we do the crisis centers for all of that. So we have 180 people in this crisis center that I can get them with appointment. I can get them in the pediatric office within an hour. It's by regulation they have to be. So the nice thing is the pediatrician, if needed to, if there's a crisis right there, we can call the crisis team, they'll be there. And we have a cactus crisis team under that. So anywhere in Allegheny County, I can get a crisis team within their hour if they need it. But also we have a big psychiatric ER. We did about 14,000 visits. They can be seen there within an hour or two. So we have two quick mechanisms, because in this practice, they can handle most things there. But if they're acutely, very suicidal with the plan, they'll be able to refer on pretty quickly. I show it later on. I thought there was going to be a lot more referrals. 10% or less are getting referred on for more severity. And sometimes we see about 7 or 8%. And they'll go to Dr. Brent's Star Clinic, which is an awesome clinic, or they'll go to the CAPS Clinic, which is Boris Biermeier's Polar Clinic. They'll go to those clinics if they need to. And we have a really good show rate, by the way, too, because you've hooked into a therapist that actually somewhat belongs to that. So our show rate when referral is very high, because you've got, hello, I'm Dr. Crum. I'm working in the pediatric practice. I'm seeing this kid because I'm seeing this kid today. I'm going to send him down to you, and I'm going to follow him up. If he stabilizes, you want to send him back to me, I can send him back. A lot of them will stay with the specialty clinics, but that way it feels like more. So even the referrals have gone much higher than you expect. This shows you a little bit of our care models. I didn't want to bring on my slides, but we have care models written up around each of these disorders. We have really good people in our department that write these things. So we have a really good care model for ADHD. We have anxiety. These are all treated. These are the primary things in the clinics: anxiety, phobias, OCD. We do have an OCD clinic, a really good one, and a really good child one. Shoshana Shear runs that. If they need the OCD clinic, what's amazing, after they get stabilized, they can be followed by some of this in the pediatric practice, but most of them will go down and get an OCD assessment, get stabilized there. But OCD they can treat there. Adjustment disorder, depression, defiance disorder, recurrent abdominal pain. We will see, like my child didn't have a psychiatric diagnosis. They have sort of a family anxiety. That was funny. I always wondered if the mental health clinic would have handled me as well. They probably would have had to make a diagnosis. It's interesting. They were fine with me being a parent problem, not a kid problem. But it was interesting. Recurrent abdominal pain is a very common referral to our clinic. So we aren't sort of, the way we bill it, we're not like, we don't have to make a diagnosis. Most mental health clinics, you feel like you have to make a diagnosis. Here you don't, but a lot of recurrent abdominal pain would be another one. Endopresis, enuresis, nice protocols. Pediatricians love that we can work with this. Grief and loss, pretty common actually. So if somebody comes in, they say, well, my aunt just died, my kid's been having trouble 3 or 4 days, we have a nice grief protocol, so they can go right into the grief work and loss work. Parent management training is interesting too. We do, that's been one big request, and we do have that as a training. Somebody at lunch asked me a great question about, can we do it in groups? And I think we don't do that yet, but I wrote a little note myself. I think it's a good idea. We don't do it in groups right now. It's hard to figure. It's actually, to be honest with you, I think it's hard with space in the pediatric office how you would do the group, but that's a good thing to bring up. These things we don't usually do. Autism or spectrum disorders, a PDD, we don't usually treat them in that clinic. We probably do refer most of them on because they have a better, but we will do the assessment, things like that, but we will go to we do have a pretty big, Marty Lebeski runs a really great program that we refer to. We do actually, it's funny, we do a lot of screening. Our clinic there, we get most of our diagnoses are made now for 2 or 3-year-olds, like 3, 4 in that age group. That's when we're sort of making in Pittsburgh. And then they'll get referred on pretty early. So that's not a common thing in the pediatric practices because they've already been diagnosed. Most of our kids are all getting them before 5 a diagnosis and then getting referred on. So that's not a big one that comes to this clinic. Child abuse and neglect, that's if it's a primary concern, we probably don't treat in the clinic. Developmental delays. Substance abuse is interesting. I was looking and I think same with our screens. I was looking at all the screens we've seen. That seems to be underreported on everything. I think we missed that. I talked to somebody this week. We are going to write a grant around that coming up about substance abuse and how to early identify it. Problem is I don't think we get that many because we're not screening for, we're not looking for it, and it's sad we do not treat that in the clinic. Complex or severe psychiatric disorders we do send on, especially if there's a lot of comorbidity. Even with that, we refer less than 10% on. Principles of this model. Early identification, like I mentioned, it's usually 2 years. We are getting kids younger. We use empirically based interventions. We have an access really quickly to a child psychiatrist if needed, and service is part of the pediatrics. And brief interventions too. We do try to make sure our models are brief. Now, I showed you 476 kids get 6 on, so we do some ongoing care. But we do more brief interventions. Most of our therapists are all CPTers. CPTers. We do some IPT, IPSRT, but a lot of them are CPT. Timely access to more intensive services. We found out that if you get them, we want to get them within that day. A lot of it because a lot of the volume of this sort of is being treated out here. The specialty clinics are more open too, for that too. We do have an ADHD clinic, for example. Our ADHD clinic on site at the main clinic site, probably it's probably actually mild ADHD's ADHD comorbidity gets there. Principles of operation, that the behavioral health provider's got to be part of the pediatric team. The parent support at the pediatric office, we sort of dig into everything there. For example, the billing person is not a behavioral health biller, it's a pediatric billing office, it's a provider. All this stuff is in that pediatric office. We don't pull it out. And that was a little bit, I've had trouble, not to complain on film, but the adult world. The family practice right now, I can't get the same support I've gotten in pediatrics, because that takes a little bit of time. Behavioral health, how many people think it's harder to get an authorization for behavioral health than it is medical care? You don't get the pre-cert. They still think when I was teaching, how you have to get pre-certed for this? So it's a little bit different. Behavioral health, but we're working on that. And no handoffs is a big principle. There has been some difficulty with cultures. For example, in the document on the epics, the therapist, like when our therapists document in there, now that's gone a lot. I mean, mental health's getting more medical. I mean, E&M billing for psychiatrists has made us very medicalized, and the child psychiatrist notes look very much like the pediatricians. That's not a problem. But also, when you're doing the therapy, what do you document there? What do you keep? That's been a difficulty a little bit too. What we've been training about how you get in the culture of the pediatric office with that too. The fear of opening, we screen, we're going to get, having the therapist there in the office, we don't have that problem now, because I think that's, you brought it up several times, great point. People are worried if they start questioning screening, what are they going to do? Now we're starting to see much higher rates than you would suspect, and partly because they're not afraid to open Pandora's box because somebody's going to help them with it too. Supervision is real important too, that child psychiatrists coming out and meeting with the therapist and talking on a regular basis is the therapist, we have a good retention rate of therapists in practice, because they really feel like they can talk to a child psychiatrist like that, they can talk to a pediatrician. We've hired some great therapists. I mean, they've been wonderful. We've had a high, because they feel like they're part of a team. And that's been helpful too, so they don't feel like they're by themselves. Here's some, I guess I get to some challenges here, a few minutes. Payers. We've had a little difficulty trying to get all this, making sure we get it paid for behavioral. We have tried some incident too in one of our sites. I want to cover up the video on this. We did get the payers of approval of this. One of our sites, we actually did incident too. If you look at a practice, I did the money on this, if you do a practice where if you build Incident 2 versus behavioral health codes, the amount of money is amazingly different how much you bill when you do Incident 2. Incident 2, who knows about Incident 2? Raise your hand. So when the nurse clinician sees a patient and they build under the pediatrician, that's a much better rate. People look at how much we get paid in mental health, it's pretty poor when you look at assessment or those kind of things. But if you do it under Incident 2, the rate's much higher. And so that's just hard to prove about, are you doing this Incident 2? We really are. The therapist has to be somewhat supervised by the pediatrician, those kind of things. But it financially makes it much more sustainable. Also, I like about it because it does integrate them with the pediatrician very much closely. So we have done some of that work, and we also really negotiated, try to get better rates just for basic mental health. I actually texted our biller, I thought somebody had asked me all of our different codes. We are using some of the new codes that have come out too around E&M billing. We're trying to be innovative with that. High productivity requirements, one of the problems we have there is the pediatrician office is so busy. I mean, it's amazing the productivity standards. It's much different than mental health clinic. The one thing the therapists don't like here is the show rate's 96%. You have no time for paperwork. 96% show rate. We did a cross-population, like the same in a Medicaid clinic, we got 48, 46. So one thing is that you don't double book here. Like a mental health clinic, you don't want to book because you have a 96% show rate. So the productivity requirements have been higher in this practice than our normal clinic. So that's helped it be sustainable, but there's not much downtime to do your documentation. But it's not a licensed clinic, so you're doing much more like a normal note than versus a million treatment plans and things like that. I always think, I do a lot of adult work. I mean, on the billing side, you take somebody does a neurosurgeon does a procedure like a glioblastoma, and you do a psychiatrist, what they have to document, it's about the same. It's very interesting how much mental health has got so many regulations and so much we have to cooperate this and this, and so partly it's really streamlining. We have two people internal that are national experts on how to code and how to do the right documentation. I think it's part two. We've worked the pediatric practice. What do you have to document? And make that even protocolized too. If you're doing protocolized treatment, it's much easier to protocolize the document, so it's much easier to do. Because then you have macros you can do right there in your note that you're doing. I mean, I really believe, later on, I've got I'm a high fidelity person, so I really believe in individualized care. But individualized care doesn't mean I make up everything new with every patient. So if you got somebody with anxiety, you should be doing CBT pretty much like somebody else's CBT too. It should be individualized, strengths are different, but the cognitive therapy itself should be somewhat protocolized. Confidentiality requirements are really important. How you work on those is very important. I feel much more comfortable because the pediatrician just introduced you to the family and said, hey, you're going to see this person in their office. So we've had less problems with confidentiality. Liability is interesting. Later on I'm going to mention, we did a Staunton Farm grant to train the pediatricians. We asked them for topics. And we did, David Britt did a wonderful 2 or 3 hours on how to do, he did sort of similar talk you'd hear to pediatricians, how you do prescribing. I did a talk on liability. What I did was I brought in our head lawyer from our system, and we looked at 30 years of liability suits across pediatricians and psychiatrists. Who do you think was higher? Who gets more suits? Psychiatrists, raise your hand. Pediatricians, who'd raise your hands? It was much more pediatricians. Actually, doing this kind of work doesn't increase your liability at all. I think some people think they don't screen for it, they're not going to be liable. That's not really true. The interesting was we actually pretty much showed them that liability, because you're screening and doing this, the liability doesn't go up. If anything, it may go down. So we had to do a lot of work on that to make sure they felt comfortable with this, having the therapist in their office. The medical leadership buy-in, I think was really important, was from the very beginning. When we run this committee every month, the pediatricians have really felt like it's their practice, not mine at Western Psych. The therapists are theirs. They really feel like this is their behavioral clinic, not Western Psych's behavioral clinic. That gets really, really important, and we've got some great leaders on this. The expansion of the pediatric role to embrace behavioral health, it goes right along with the medical home model. I mean, pediatricians are used to taking care of everything for their patients, so this is not a big jump for them. They want this. They want this to happen. Strong office manager support. This was a little difficult because trying to make sure that the office managers really bought into having this new office, a new person to see, and that overall that's gone well, but just making sure that office staff understands how it works too. The most you can make it where they have the same sign-in sheet and everything. The first time I signed in, it was sort of, there's a sign-in sheet. There's John Smith. There's my name, Ken Nash. My child's coming in. I thought, this is going to be weird. My kids used to come into pediatrician. They didn't know whether I was coming to pediatrician or see a therapist. The nurse would come out and get me. I would go back, and then I'd go to the therapist office. I mean, they didn't know if I was coming to get my kids' ear checked or get the therapy. Sometimes I would forget. So they wouldn't know that. So they wouldn't know they go there, too. Much better that way, too. You also, as a parent, you also feel easier. We only went 4 times. You feel easier to let go at that point because you know that if you want to come back, they're right there in the same office. You don't think, I didn't got to see him 5 more times or I'll never get to see him again. So it also, too, the therapist goes, I worked all this time to get this kid in, and now I'm getting a turnover. New kids are harder than old kids. So that goes away with this kind of model. Strong psychiatrist presence and accessibility, timely access to our psychiatric evaluations, timely access for brief phone calls. Most of our people that are psychiatrists doing this now are doing other things. That makes it much nicer, too, because they're not pulled out. Some of our people are part-time, but it makes it better when you have dedicated people doing it. So that child psychiatrist, if he's full-time doing this, or the triple boards, it's much easier if they're there. We have a model now. We've had a few people as pediatricians that are triple boards, and they're doing some of the therapy. We'll see how that works. Available for follow-up, available for teaching and ongoing support. And Greenie, too, we've hired, this is a good one, too. We've actually hired, our average clinician's been I didn't realize this until I was making them up, 10 to 25 years experience. We have put our therapists a little bit more experience in the practice. That may change if we've hired the second or third therapist in that practice. You may have a model where we have some more junior therapists. And part of the pediatric team, not separate. And it's important, too. A lot of our folks like this much better in a mental health clinic, too, though. We've had more, people like that setting a lot. Especially when you have that show rate. The show rate just in itself is really, people hate, they have all these skills and they're sitting there waiting. They like that too. Share responsibility, these are really hot. We have a hard time at the main site because we use a different product than Epic, and I think that the shared medical record is really important. If you have a separate medical record, I think it's much harder to do in all your settings. The EMR part identifies the referring position. I think that identifies the collaborative team. It has the behavioral symptoms, type of intervention. It's very focused how we talk. I used to do, back in the 90s, I used to have trained some of my psychiatrists. They would be people that people that document all these dreams and all these things. And I was like, you could have that, but these were back in even the state hospital, they had these 3-page notes on patients. You feel like you're documenting a lot, but in the pediatric office, they're not going to be able to read that. So we really focus on what we're doing. I mean, if they had a dream, you can document positive dream, but you don't need to put everything in the whole world there for it. Document the communication between the team members is important. Here's our results. We did, let me make sure. We did 12,000 visits in 2011. It's increasing about 20% a year. The need is there. It's funny is our main site clinics were just as busy as ever. When I did school-based back in the 90s, it was very interesting. People would go, when you go into a school and you start looking and you cannot believe how many kids need it and do not get it. So it's not like we're all of a sudden, taking away from our main clinic is about as busy as it's ever been. But in some ways, there's such an unmet. It's just sad how big the unmet need is. And so I think we'll keep on increasing like this, but it's pretty amazing. Rate of share rate's over 90%. The normal in that same kind of clinic is 48-62. One thing we did do a little bit backwards, which has been interesting, we started it a lot in our suburban clinics, and there was a very good payer mix, mostly commercial insurance, and then we worked into the Medicaid clinics, and now we're in the Medicaid in the cities. We worked backwards that way. Now we're starting to do some rural clinics too. I should mention at a time, we have a pretty big telepsychiatry program. We do about 60 to 80 hours a week of psychiatric time and doing tele. We have not done tele to our pediatric practices yet, but we are starting to think about integrating all of our tele into pediatric practices. Do anybody use our tele? We're putting a lot of counties, some out this way. We do tele to mental health clinics mostly. We have not done tele to the pediatric practices. We have a few interested. I think that would be great. Because when you go to Erie, we're thinking about Erie, we're thinking of a place like that. When the therapist, I don't think I'm going to have a child psychiatrist be able to travel up there for 4 hours a week. We'll probably use tele that way. I had a bunch of slides, and I was a little afraid to show it because I don't think the data is that good yet. But we've been looking at our medical utilization of these patients. We are starting to see early on, we believe the medical utilization of these patients is much less than their control group. I have the slides. I don't think the data is right yet. I was going to show them today. I thought you'd be the first to see them, but I don't think we're quite right there. But we are seeing, when we looked at these kids, that they do look like they're using less medical services, less ER visits, and they follow up the pediatrician less. We are going to start doing that data. We also have psychologists we put in, the asthma diabetic clinic in the main hospital. That's that part of this presentation. I think we're going to show more medical offset in that clinic. So we're starting to look at that. The medical offset, as mental health, we've always said it was there, but there's not been that many publications that really show it. I think this is, how many people think that mental health offsets medical cost? Raise your hand. I think it really, because it looks like in this group, people, because if you look at it, just how many stomach aches will come into a nursing station, I think that could be useful. Also, we did show, and I didn't show that, I'm not ready to show this data yet, we are showing that they use less psychiatric ER and less inpatient hospitalization too. To be honest, that data wasn't as robust, as robust as the medical utilization. But both of them, I think, were offsetting. One of the problems is cost avoidant. In my other grants, I take kids in residential and bring them home. That's pretty easy to show cost offset. Now I'm talking about 12-year-olds, and you're almost cost avoidant. That's a little bit harder to show when I'm getting a 12-year-old. And luckily, he may not go on and develop a lot of comorbidities, but it's harder to show that cost. It's cost avoidant more than cost that too, but it's important too. Couple of things about the clinic. We have won 2 awards. One award we won was the HAP award. The hospital was really cool too. I like this one because it beat all the medical. This was good surgery, OB, everything. We won the 2012 Patient Care and Innovation Award to the Hospital Administration for Pennsylvania. And that was early access to behavioral health in the pediatric home. I'm very proud of winning. And the other one we just won in 2012. We won another award, the final award for teamwork excellence and transition of care. So it's getting some sort of recognition, which is nice too. Couple things before I go. I have to give Abby Schlesinger, who just had a baby. She's awesome. She's the medical director and does the day-to-day work in this clinic. Have to give a shout out to Abby. She watches this. She's awesome. She really is one of you need a few, people, a lot of you talked about leadership. She's shown great leadership, as has, I should bring in Chris Gessner, who is the head of Children's Hospital CEO. He's been very invested in this. And Claudia Roth, my boss, the CEO, has been very invested. And Dave Lewis, who's my chairman, all those people have been from the very top, have thought this is a great program to do. So I think you have to have some of that leadership at that level. It's been helpful that we've won a few awards lately and those kind of things. It's been helpful to show that. So I think that's important. I want to bring up 3 other things just at the very end, branching out. We did get a Staunton Farm grant that was really nice. The grant did 4-part series for pediatricians. Dave Brent I was part of it, Abby Schlesinger. And we did a follow-up of the surveys of all the pediatricians that attended, and there was a change in their practice afterwards. And the follow-up, they increased their use of evidence-based interventions and medications for the year after we did that. So we did that. We did a year of that too. That helped in this other part because the pediatricians, in the long run, if you use lots of child psychiatry time, it's hard to make it financially stable as much as having the pediatrician take some of the maintenance meds. 2 other things. I don't know if anybody heard of high fidelity wraparound. The other grants I work on is the Youth and Family Training Institute, which is statewide. We're about 1,000 kids. We have 25 in Philly. We're doing this whole thing across the state of doing high fidelity wraparound. The reason to bring it up now is we're going to try to do that with the pediatric practices now. We're going to try to get 1 or 2 of the pediatric practices high fidelity wraparound. High fidelity wraparound takes We take family members that have been through mental health and train them up as family supports. And we take youth that have been trained up, they've gone through the system, they've been in residential, now they're in their 20s doing better, and we train them up as youth support, and we bring them back into a model called high fidelity wraparound. We're going to try to do this with two or three of the pediatric practices, try to develop youth and family groups across those pediatric practices, those with mental health, and maybe do family support and youth support in those pediatric practices. I think that could be very interesting. And the last thing is, everybody heard of system of care? We've got a couple of system of care grants. Stan Murkowski, who has been our leader at the state level, and the system of care, I think, sometimes does play down pediatrics. Pediatrics is not at the table as much as they should. So even our system of care grants, we're looking at how we can make sure the pediatric and those are at the table with those grants. Which the grant we have now is juvenile justice, foster care, and the early data on that grant is very interesting. We have of the kids who are in the juvenile justice system, 71% are leaving juvenile justice by the end of the grant. 54% are leaving foster care. So I think both of these grants, I think, will be interesting now to pull the pediatrics into that, especially now that they have a behavioral health presence in those practices. I think it'll be really easy to buy into those other projects too. So, is that enough? So to follow up too, by the way, I've been really amazed by today. I think I've taken more notes today from speakers. I think that what we do, and I think a lot of therapists out here, I think this is very, 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 very important work. I didn't bring up suicide. In fact, we do screening. In fact, I think we may need to use your scale. We use 3 scales. We do the SCARE, we do the PHQ-9, and we use one other one that I was looking at this. We use 3 scales, but we probably are not doing as good on screening at the front, and we need it, since we're not a grant, I think we're just starting to study a lot of our outcomes. I wish we'd screen better and study better in our outcomes. We're going to keep on trying to do that better. Any questions? One question. Yeah, I don't know. What's interesting is, I think that you're exactly right what was said earlier. A lot of things in medicine get paid for. Right now, the way we do it is the therapist brings them in and does this. If the pediatrician thinks there's anything, they're having their first session, so that we're billing a CPT code, we're billing a therapy session. That's not really practical. I wish we could. It'd be much better to have I don't think we can drop a bill in behavioral health yet for a screening school, but I think there is a lot of push. It'd be much better if in our model, if we had a screening tool up front that could be paid for. We do not have a code to pay for a screening tool right now. I think other people are going to talk about that, but I think that would be great if we get that approved. That would be really good.
I thought there was some agreement with Highmark to reimburse for screening.
There's been discussion about that. We have not been able to. You know what? They've been trying to do it with the depression scale, and I don't know if it's been paid yet or not. Is that statewide or just in our area? Yeah, I'll get back to you on that. I didn't think it was. It's almost like the E&M billing. You know, it's all who's billing E&M now? I mean, it started in January, and by the way, the rates are better in E&M, but it's been hard for people to get picked up. I don't know if we're actually getting much reimbursement on that. Well, the good thing is, the reimbursement goes back to the pediatric office, so that would be great. It could offset some of the support of that therapist in their office. I think one of the big innovations in our model, it sounds small, back when we did this in the 80s, we put our people in there. Now it's their people in there, and it makes it much better that way too. With them, the therapists actually belonging to the pediatric office, and it's hard to do. I've been trying now. Any family practice doctors, we're trying to do that in family practice. After they got over it, now they're actually making some margin, and it's more sustainable. They're bought into it. That's hard to think about how you're going to do that. I think it's a very important part of the model. Thanks. What's your question? Andy? Right.
I'm assuming that all insurance is including Medicare, etc. They are billing under the pediatrician.
No, most of them are billing under their own license. That's a great question of their private practice. We have a site that we have tried the incident to, which is much better financially, but only a couple payers are recognized that you can bill as incident to. Does that make sense? Most of our therapists are working under their license.
Right. Okay.
Yeah. Yes.
So the consultation piece is not 100%.
Well, with the child psychiatrist part of consultating? Yeah. That part, that's why we had to have 10 therapists to sort of do it, because in some ways the child psychiatrist will see the patient. Let me back up. The child psychiatrist will see some of these patients directly. I mean, I should go back and look. I bet we did 2,000 or 3,000 child psychiatry visits last year. The therapist sees them. They feel like they need a child psychiatrist to see them. The child psychiatrist will come to site, or they'll go back where there's a child psychiatrist every day in the pediatric hub, and they'll get seen there by the psychiatrist, and then they're billing E&M codes there. Right. That's so. But I love it. I would like to do like other things, like they do asthma. Like a nurse practitioner sees that patient for asthma, bills it as 80% of the pediatric charge. I don't know why they treat mental health that much differently, because it's still a, it's that ADHD pretty much is in the domain. I mean, a lot of them are pediatrics. So I don't know. That's what we're trying. Some sites will.
They're not licensed to do the mental health. I mean, they can't even bill for depression, can they? Pediatricians.
Well, it's interesting, by the way. If you look at 70%, well, some studies, 70% of your antipsychotics are given by pediatricians. So they're billing something during those codes to get the psychotropic. So they're billing an E&M code. So it's an interesting question, because they can't. They are billing. They're billing for the medication, but the therapy part. What's that? Yeah. So it's very interesting.
In the
But how are
survey,
they billing Medicaid if it's not a licensed site? How are the clinicians, the behavioral health clinicians?
They're having it. That's when we've gotten community care. They're recognized as a individual person under Medicaid. It's for the well, actually, some of it's through Children's Hospital too. Yeah, it's a very quick question. The question now, that's been more complicated in the Medicaid area, heavy areas. How do you get the individual? And usually they do as a licensed clinic. So that's when we started all in the commercial areas and working down because of that too, because the commercial insurances have been easier than the Medicaid to do that too. So also the rates are different too.
well, in a state survey we did that I mentioned, 60% of the providers said they paid out a medical disorder in order to treat behavioral health. Some stomach pain disorder.
Right.
Treatment to see his depression.
Right.
You can't really
That really varies by state. And Massachusetts, we're lucky, all the payers now have one. Primary care can bill whatever it is.
You said,
The ability for primary care docs to bill for behavioral health work really varies by state and insurer. And in Massachusetts, all the insurers in the group except one moved to allowing primary care to bill whatever is appropriate for the patient. They have to only use E&M codes, but so they're not going to do therapy, but they would do therapy anyway. So, but if they can see, if they see someone for depression, they put them depression.
There's no question here.
I may have missed.
Oh, my.
I may have missed this, but it's quite a large system you have in place now. Could you talk a little bit about the size that you started with and how you decided to expand? And then, I'm sorry, I have a quick second question, which was you mentioned a really great show rate, and I was wondering if the practices do anything in particular to support that beyond reminder calls, or if that's standard or whatever.
Both good questions. That's what I said. A lot of stuff, like even tele. My first televisit was 1998. I did tele, so it's like everybody thinks it took us a long time to get to where we are now. We did a pilot for a long time at Armstrong practice. Shout out to great practice. So we tried all these different models out. Partly was, this sounds weird. You think about billing. It's also, where do we do the space? The pediatrician's office are pretty tight. I didn't put this on there, but some of the barriers just, where is the space going to be where it's not so loud that you can do therapy? Little things like that. I think a lot of head shakes on that one. So it's interesting, though, we had to work on that. I mean, we had to work on those things in the pilot to say, we had to go, if we go to this next pediatric office, here's what we have to have. Before we start there, do we have space? Does your office manage? It's a lot of work on the office staff. Are they going to be able to get the pre-cert for insurance, those kind of things? We're doing okay financially, but sometimes I worry we are causing some burden on the pediatric practice, because it is. But actually, if they get going on it, it's very easy. But we did do a pilot back in the 90s, and now each practice has to have a certain things. You have to have a pediatrician who really accepts this. Luckily, that's sort of got the pediatrician that really feels comfortable with it too. We started out so the pediatricians, the beginning ones, felt very, very comfortable with this model. So that was important too, because what happens too, people start coming there from other pediatrics offices sometimes to get the behavioral. Oh, one thing we did too, this has been a little bit, because most of the time, there's some exceptions. If you want to see that behavioral therapist, you had to belong to that pediatrician. So one thing we had trouble was everybody goes, wow, there's finally a therapist here that will see us. So then they get all these calls to get the therapist without the pediatrician. So right now it's pretty much, you have to come referral from that pediatrician, because it's just need. So that's one thing we had to go. The other question was, yeah, it's interesting, by the way. We had this about 10 years ago. I did this clinic called at Oak. It was the Open Access Center, and I started out. And we got everybody appointment. This is adult. Within like a day or two, my show rate was above 90. So they see me on Monday. If you go 3 days out, I wish we published it, it just dives. So partly it's how quick you have your appointment. If you wait 5 days, you're cutting it to 70. So the problem is we have a pretty quick into the next session. And that's hard too if you don't have pretty good productivity, so people get discharged. So that's the problem too. We still, once you schedule people 7 days out, the one thing bad about mental health, if you have an ear infection, you have a fever, you probably continue that fever a week. If you have a crisis with depression, you still have depression, but you may feel better 3 days later, you're not going to come in. So with mental health, I think especially for retention rates, it's how close you get to that referral. That seems to be a big deal too. If we can get them close to that referral, also meeting the person is important too, that you meet them and you see where the clinic is, you're not driving somewhere. Yeah, I'm surprised that every time, now we are moving to clinics that are more Medicaid based, and I think our show rate's gone, I think will be in the 80s, but it's still much better than the other clinics too. So you don't worry about as much, they've already worked out some way to get to that pediatrician's office. That's the same with a therapist. So that's a great, I think the show rate also helps you financially. I mean, mental health, the biggest thing in mental health is very difficult with that because the show rate's low. Good questions.